Welcome to today's webinar entitled Meet the Experts, a conversation with Eric Dalton. I'm Katie Colleton. Now let me introduce Ben and Eric. Dr. Benjamin holds a doctorate in sports medicine and education and is a well-known and respected educator, author, and practitioner in the massage therapy field. He is also a communications consultant, business coach, writer, and entrepreneur who has been teaching massage therapists for more than 30 years and has been in practice for more than 45 years. He is the author of dozens of articles on injuries, as well as the text Listen to Your Pain, Are You Tense, and Exercise Without Injury. He also co-authored The Ethics of Touch and Conversation Transformation. Eric Dalton earned his philosophy and clinical psychology degrees from the University of Oklahoma. Eric has practiced manual therapy for more than 33 years in a variety of clinical settings. He is the founder of the Freedom from Pain Institute and the author of 2 textbooks, Advanced Myoskeletal Techniques and Dynamic Body, Exploring Form, Expanding Function. An influential seminar by Dr. Ida Rolf in 1972 launched a passionate mind-body adventure which directed Dalton through a series of educational institutions, including the Menninger Foundation, Mueller College of Holistic Studies, Michigan State College of Osteopathic Medicine, and the Rolf Institute of Structural Integration. Welcome, Ben and Eric.
Thank you.
Thank you, Katie. Thank you so much. And thank you, Eric, for consenting to do this with us. It's a pleasure to have you. So, Eric, what drew you into this field? Was there some pivotal experience that made you decide to take up bodywork and massage therapy as a profession?
My mama used to say, Eric isn't happy if his hands aren't busy. And that started me in drumming. I started a little high school band, and we were in a college town, University of Oklahoma, and became a pretty popular fraternity sorority band, and ended up in Detroit, kind of backing up some of these guys like Marvin Gaye here at the famous Rooster Tail Club, and ended up getting a record contract and going out to California, and ended up with that what Katie was saying in the introduction about the seeing Ida Rolf in 1972 and being influenced by her work. I went to see Fritz Perls, who was co-presenting with her, and so it was a pretty exciting time for me. Here's Ida Rolf, and we had an experience over there at the Esalen Institute where I went to see Fritz Perls and ended up falling in love with Ida Rolf. But I couldn't find a Rolfer when I got back to LA, and not until the late 70s until I finally got in to see a Rolfer, and it kind of changed my life, and I've never looked back. I've had a passion for body work ever since.
So what did it do for you when you had your first session? What was that like?
Well, the Rolfer was a very experienced Rolfer, and I was a very inexperienced body worker, a client, I guess you'd say. I'd had some therapy in LA, some chiropractic work, and a little bit of physical therapy work because I had a scapular problem that turned out to be some jammed up ribs from sitting in the recording studio hitting that 2 and 4 beat with the snare drum on my left side.
Right.
Now, yeah, and no one had ever been able to help me. And this guy, after session 3, well, the first session I was enamored by it, fell in love with it automatically, but it wasn't as a thinking I'd ever want to do that. I just was touched by somebody being able to change my life, particularly by session 3. I'd had this lingering problem for 4 years, and he really helped me get rid of that pain. And when somebody, particularly in our day, back in our day when most of us got into this therapy because someone has touched our bodies and changed our lives, and we go, I want to do this. We didn't get into it because there was money involved, because back then there wasn't much money involved in it. But yeah, I still have a passion for this work, and I probably always will.
And how did Vladimir Janda affect your work?
Well, Vladimir I happened to see by accident. I was going to Michigan State College of Osteopathic Medicine taking their postgraduate workshops with Philip Greenman, and he came through. and I had really never heard of Vladimir Yonda. That was 1992, and he was just a enigmatic character, very sweet, very big heart, and he was not really real well. He had had polymyelitis as a child and was in a wheelchair for quite a while, and that's where he developed his keen visual sense. He watched people play and watched people move, and he used to tell Phil Greenman, if only you had my eyes or I had your hands, because he had just great visual observation skills that Ida Rolf too. Those two both were we used to sit in malls and watch people walk and analyze their structure. So that's a gift that takes a long time to develop. I know Tom Myers does a body reading course that's very good, but it takes many years to develop that skill, that gait analysis skill.
Right.
Yeah, but Vladimir, he was just, what I got from it is the upper and lower cross syndrome, which were a simple pattern that I've been seeing, and Ida Rolf had seen the same pattern forever. Our flexion-addicted society with the tight iliopsoas and hip flexors and weak inhibited gluteal muscles and weak abdominal muscles, and then, the upper cross syndrome with the tight pecs and the weak lower shoulder stabilizers those patterns that we see all the time in practice. Well, Vladimir Yonda, when the Iron Curtain came down, we were wondering why all the gymnasts in the East and all of the athletes were so great. Well, that St. Charles University there in Prague, they had Carroll and Lewitt over there, and dozens of excellent researchers, and they were using the new Noraxon electromyographic equipment. And their goal, oddly enough, was to try to determine what they said, how can we ever create a perfect body if we don't know how muscles fire during movement? And so that's what they did. They hooked people up with electromyographic equipment and tried to determine what the gait analysis looked like on electromyographic machine. Well, that didn't actually work, but what they did find is that when certain muscles were put under stress, they became tight and facilitated, and when other muscles were put under stress, they became weak and inhibited predictably. And so that's what they started studying in the upper and lower cross syndrome. As soon as I learned that from him, I tagged along a few conventions that he was teaching, and I immediately started using that in 1995. When we started teaching in my garage, the Dalton attachment technique, I was using the upper and lower cross syndrome and developing techniques for that. And then in 1998, when I put my first home study course out, it was kind of based on Vladimir Yonda. The book and all that stuff is dedicated to him.
Eric, what about Greenman and Sergey? How did they affect your work?
Let's get into them. Let's see here. Phil Greenman, of course, the first time he was head of the Michigan State College of Osteopathic Medicine, which was the hands-on part of osteopathy, and for 35 years. The first time he worked on me in class, I knew that was the body worker I wanted to be when I grew up. And then the more I got to know him, the more I realized that he'd probably forgotten more than I would ever know. I mean, the guy just went smoothly from one modality to another, never even knowing there were dividing lines, from deep tissue work to muscle energy to high velocity thrust to cranial to visceral, whatever the person needed. There were no imaginary dividing lines that we use in our work a lot of people, and that's what I wanted to learn to do, and I realized that it takes forever to do that, but it's a goal worthy of achievement. So anyway, Greenman, he was going to retire because he had a bad back, and that was 1992. So every 6 weeks they have 20 postgraduate workshops that you can go to up there, and so every 6 weeks I was up at East Lansing going to class because I was afraid he was going to retire, and he just kept getting better and better, and with some functional movement stuff actually that Mark Bookout was doing, and so I ended up going for 10 years to those postgraduate workshops, taking them over and over and over and over and over. So anyway, that was a wonderful experience with Greenman. He's now retired and living in Tucson. And then Serge Grakovetsky, I had met him in the 80s. He came through to the Rolf Institute at our annual meeting and gave an inspiring presentation. Of course, he's a nuclear physicist from retired 27-year tenured professor from Concordia University in Montreal. And he was, those of you who were at the first Fascial Congress know that he was the guy that got the standing ovation the first day, the only person who got the standing ovation for his presentation. Extremely funny guy, but mainly he took his physics background and his back pain that he had and started studying the biomechanics of back pain and how the body moves, particularly how it propels itself through space. And his thing was not that the legs did not propel motion. He came up with a completely different theory that was put down when his Spinal Engine book came out. The experts put him down, but eventually I think he's won over. So I have been studying with him for a long time, dedicated my last set of DVDs to him, and he's an author in my new book, and I'm just pleased to even know this guy. Just a brilliant, brilliant mind. You there, Ben?
Eric, what do you enjoy most about being in the field?
Which field? Well, I live
in the massage therapy field. In this field.
Okay, not the wheat fields of Oklahoma.
Not the wheat field. No. You probably enjoy that.
I'll tell you what, it's just right here, man. You were just there yourself, being around people with passion for therapy. These pictures, I think a couple of these pictures were taken there in Pura Vida in Costa Rica. You were just there a couple of weeks ago, and
yeah, it's great, beautiful.
Yeah, isn't it a great place? This was our last year's class picture, and of course I've retired from teaching the 3-day workshops, and I'm only teaching one convention this year, and maybe a Costa Rica retreat, but I doubt it. This guy's now teaching for me. Can you see my arrow? Is that
yeah, we can hear it.
Okay, well, this is Paul Kelly from Knoxville, Tennessee. He's been with me for over a decade, and he's been teaching for several years. Not only a structural body worker, but he also has an exercise physiology background and excellent teacher. And so he's teaching several workshops this year. This guy right here, Nick Kress, with the "Man Boobs Are Sexy" t-shirt on there, is a great guy, and he's going to be teaching some workshops for me. But this is the gal that started it all with me, this Kim Miller here. Her and I started in my garage, like I say, in the mid-'90s, and she's been with me except for 2 workshops ever since. And she is head of the Teachers in Training program. And so, I've just got wonderful, wonderful TAs. My teaching assistants are great, and I just love the learning and bonding experience of people that are in this industry, particularly the people who got in it for the right reasons.
Mm-hmm. So lots of people who are in the field, who are therapists, usually take care of other people, but don't necessarily take care of themselves very much.
That's right.
And I'm wondering how you do that. Do you take care of yourself? And if you do, how do you do that?
Yeah, I'm going to answer that question, but I want to also show this slide real quickly.
Oh, okay, sure.
This is Costa Rica, and this is some of the stuff that you could expect if you go to any Costa Rica retreats. I know Tom and Ben are planning on doing another retreat, and so you need to get to that. This is actually Tom right here in our workshop that we taught 5 or 6 years ago at Pura Vida. And one thing that you always can tell about, is this where I push here, this and this? Okay, this is how you can always tell that you're in a Tom Myers workshop, is this right here. He's always got somebody in their underwear. This is Tom, and he's also got his arms in the air like I think he's some sort of minister. He's always very elaborate in his presentation. Great guy. Also, let me just bring this gal in. This is another thing that's fun at Pura Vida is this zip lining. Did you get to go zip lining while you were there?
Yeah. No, I zip lined all over the place. It was great.
That's fun. That's a great time. So anyway, that slide was just kind of showed some of the things that go on there in Costa Rica. We started teaching there in 2002, and they just brought us in as a yoga resort, and they had built some tables for us and brought us in. But back to taking care of yourself. The best way to take care of yourself, I know in the beginning, this is what I looked like when before I knew about fascia and stretching. I looked like this. This was Eric Dalton.
That's pretty funny.
This is the steroid picture of Eric Dalton. We had to do some heavy photoshopping to get this one together.
So that's a made-up picture. Is that really?
Do you think that's me? Come on, Ben. You know better than that. We've met. This guy's about to pop, whatever it is. but we covered up this area anyway. Yeah, so this is what the muscle heads look like. A lot of people call them the muscle heads, people who are still in the gym using the pad work. But then after a while you evolve and you come in to become a fascia head, and you get into the yoga and the stretching, the fascial fitness. I can no longer do this anymore because I was in this kind of thing in the gym and blew out my posterior cruciate ligaments trying to do calf raises on a leg press machine. So both my posterior cruciate ligaments are now loose and my knees flop around. So I no longer have really good knee flexion, so I can't do any of this stuff anymore. But I still stretch every evening. I do all my stretching in the evening, and then I do my workouts in the morning, my strengthening stuff in the morning, and my aerobic stuff in the morning. And so, yeah, it works for me.
That's
keep
great.
Going.
Yeah, that's great. Well, that's good.
And also, this is another thing, though. When you're practicing, in your practice, you've got to have good body mechanics. Now, everybody talks about body mechanics, but we always noticed that in our workshops, from day one, the people would look, the teaching assistants would come up and they go, the group just doesn't look that good. By day 3, they're looking great, and we couldn't figure out exactly what it was. And you know what it is? We're constantly coaching them on using their body, keeping their lumbar lordosis locked in, keeping their center of gravity low, sumo wrestler position. Those of you out there, just try that, standing with your back with flat without the lumbar curve, and then dropping a little bit of lumbar lordosis in and leaning into them, and just feel the difference while you're working. This gal here is in my book. This is taken from my book, and one of the first things I noticed after we shot these pictures is this right here. This is a dead giveaway that for a dancer, she's pointing her toes here, and every time she has her legs off the table, she's pointing her toes. And one of the things, she was a classically trained ballerina, and one of the dead giveaways for that is this externally rotated leg over here. Notice how this thing is all externally rotated from the plies. And I really made a mistake when I'm doing this stretching technique, this hip flexor or front line stretch. I should have come in with this foot right here and blocked her into internal rotation. If I'd brought this leg more into internal rotation, which I should have done if I'd been paying attention, I could have got a better stretch through here and a more more adequate stretch, done her a little more good. But yeah, basically it's all about getting your body weight in there and getting the and feeling deep. That's the 2 biggest problems I see with therapists, and the hardest things to teach are using your body weight and also being able to meet the restrictive barriers and go from the restrictive barrier with your deep tissue work. I always thought if I ever become a teacher, that's the first thing I want to teach is how to meet the restrictive barrier, don't bulldoze through the barrier, and then work from there. People are always asking me, do you do warm-up? Do you warm up the tissue? Do you warm the tissue to get in? My answer is always no. I never do warm-up techniques. I go till the tissue stops me and start working from the layer that stops me. I don't want to work on the tissue that's already loose, particularly in the low back where you have a lot of low back instability anyway. You do not want to go in and work on stuff that's already loose. You go to the restrictive barrier and see if that restrictive barrier needs work. You know what I mean?
Yeah.
Yep.
So it's great to hear that you're one of those people who does a lot of work, and it also takes care of yourself. And I think that's important for all the therapists that we train to learn how to take care of themselves, so they can be role models for their clients, and also to just live longer and live better, have a better life. So let me ask you another question here. Is there I know you do a lot of different techniques. You've learned a lot of things. Is there a primary technique that you use?
Yeah, well, my myoskeletal alignment is the name that I kind of put together after going through the Rolfing training in '82, and then incorporating that for many years, and then I fractured my neck in a judo fall and ended up getting real interested in the skeleton, and so I started being interested in spinal biomechanics, and I really wasn't learning it from my old chiropractors that I was mentoring under, what I wanted to know, so I started going to Michigan State, and when I started learning the spinal biomechanics there, I decided to try to figure out how to put them together and keep it within within the scope of practice for massage therapists. In other words, right here, for instance, when I'm doing facet joint opening work, I'm not really trying to do chiropractic work by opening this joint. I'm just using these bones as levers, this transverse process as levers to to get these little fourth layer muscles. They're called the groove muscles, rotatories, multifidus, intertransversarii, muscles loose. But sometimes you can't access them directly, so you have to come and go through the use bones as levers. So in this case, I've got Luke here with his arm behind him in a lateral Sims position because I want to straighten the spine so I can flatten it where he's not laying on his shoulder and side bending the spine. I've got his head into left rotation. I've got him in a little bit of a flex position because I'm asking the facet joints to do what? I'm asking them to open. And so I ask him to start flexing his head forward, and I keep a constant pressure on this transverse process, one thumb on this rib head, and as he goes forward, I keep a constant pressure. If that starts to push back against me, then I know this joint isn't opening. So I just keep a constant pressure, asking him to put an activating force through there, a movement through there, and as soon as it starts to move and that joint starts to glide forward on its inferior neighbor, then I move on. But sometimes those between the blade panes are also involved with this rib. This rib on this side will also be a problem. You'll have what's called a dual fixation. So you just come over here to the iliocostalis muscle, which has firm attachments along the rib angle right here, and you press on that. If it's exquisitely tender, you have rib dysfunction too. So then you come under with these thumbs under the rib, ask them to do the same thing. You flex and you roll this rib back into place. So that's kind of one of the things. Here's an upslip where somebody has stepped down off a ladder and the ilium has gone superior in relationship to the sacrum. That's got to be fixed. You can fix that myofascially without doing high-velocity thrust. Sometimes you can't. Sometimes you need high-velocity thrust. But usually there's a very easy and simple technique for getting this sacroiliac joint, highly painful sacroiliac joint work fixed. Of course, you've got to do all the ligament work that you teach. After that, you can't just rely on those ligaments to firm themselves back up. Those long dorsal sacroiliac ligaments and iliolumbar ligaments are going to be lax on this side in the presence of joint dysfunction. There's a bunch of different things, like you say, a bunch of techniques that everybody uses, and nothing is new. I've just incorporated a bunch of stuff, and you use your own versions of the techniques in your own way. The only reason I even named myoskeletal alignment technique is so somebody that wanted work that had to do with joints would know where to come. That knew that this person, when I come in, they're not going to do they're not going to necessarily just do a deep tissue massage on me. They're going to be starting to think, what is going on in the skeletal structure? What's going on in the ligamentous bed here? And so that is a thing. The reflexogenic relationship of muscles, ligaments, and joints. That's the basis of it. So let's see what else. I got another one here. Here's some of the techniques that we use. This is a hip capsule stretch, or can be hip capsule stretch. If I there we go. If I move this elbow down and put it here on her femur and lift this leg up, then I can start to stretch the anterior hip capsule, and or it can be a sacrum. In this case, I'm working on her sacrum and pulling this leg up into extension while I'm dragging the sacrum down in case you've got a torsion or something like that going on in here. This is a rib technique. Notice how this arm is coming under and these fingers are grasping the top rib and the scaling muscles. This arm is bringing the head into right side bending and left rotation, and then you have them push against you and you pull that top rib down. The top rib is commonly elevated because of tight scalenes, substituting for sternocleidomastoid, et cetera, or a lot of athletic people get inhalation fixed ribs and stuff like that, which is a rib that has gone up. It could go anteriorly or superiorly and get stuck there. And so this is one good way to pull it down. This is another one can be for a hip capsule or can be for a sacroiliac joint, just depending on where you work, above or below the ischial tuberosity. This is a technique I love. I invented he's got him in flexion. I'm asking the facet joints to open. I've got the leg and I'm bringing him into forced flexion, knee to chest, and I'm asking this thing to drag the ilium down, which pulls the sacrum away from L5. So I start with my fingers down here and go all the way up. And now I'm at 3-4 now, trying to find out what's going on at 3-4 here. And 3-4 pushes back against me. I know I've got a dysfunction here. So I can come around the other side, or if you're strong, you can go ahead and work it out here. This time I'm lifting this guy, and in this case, lift him up to decompress, and then I'm just putting a a force through here to mobilize to see if he's got any joint play in his mid-thoracic spine, which is a very common area where you have excessive thoracic kyphosis. And so I'm trying to take some of this excessive thoracic kyphosis out by putting a force through here, lifting him and mobilizing the ribs and stuff like that. So this is an example of myoskeletal work. We call it articular stretching, which includes all of the joints and the tissues that are involved in the joint space, ligaments and joint capsules and stuff like that.
Are there some new, I know you've been doing a lot of things a long time, are there any new and different treatment approaches or ideas that you're exploring now that you're kind of semi-retiring and having some more time?
Yes, actually, let me go back up. I've been interested in this for a while, but I'm still working on it. I'm a slow learner. Once I get something, it takes me a long time to learn something, but once I learn it, then I pretty much get it. And then by the time I get it, somebody's proven that it didn't right. So, you don't get married to any of these these theories, because just about the time you feel like you've got it together, somebody comes out and proves that you're wrong. But for right now, I love the system right here. It was introduced originally by, I don't know who originally introduced it, but Vleming, Andre Vleming, in his book, is my favorite book, one of my favorite books, Movement Stability and Low Back Pain, 1997, came up with these, he called them sling systems. I've changed them a little bit. Over here, the stirrup spring system comes through the pronatus longus or fibularis, whatever you want to call it, tibialis anterior, and it forms that stirrup under here. And it has to keep energy from driving down into the ground like the dinosaurs. The dinosaurs were the only mammals that lost energy into the ground. That may be why they're extinct now. But humans can't do that. We cannot lose energy into the ground. We have to have this ground reaction force that drives the energy back up, that helps side bend and rotate the torso into counter rotation. So what we got here is as the heel strike. In running, you don't necessarily have heel strike. But in walking, you want a heel strike. As soon as you do, it starts to flatten this arch. The medial arch starts to flatten, and it starts to tighten this system and drive this tension up through the biceps femoris muscle, up through the sacrotuberous ligament, up through the long dorsal sacroiliac ligaments, and into the lumbar spine, where it can go into the erectors and side bend the spine right, which rotates it left. And it works with these other systems. It has to work in conjunction perfectly with these others. This is the posterior spring system. It starts, I added biceps femoris. It's not, Vleming didn't put biceps femoris in here, but gluteus maximus and the latissimus dorsi through the thoracolumbar fascia. This is a crossing pattern because we have to constantly make sure that our clients have a smooth cross pattern gait. Otherwise, they're grinding and down on the discs on each side as they take a step. So they have to have this cross pattern gait that we get when we're children, when we're crawling, when we're crawling around. And this has to manifest as we stand up. Well, for instance, as we sit in a flexion-addicted society, glute max will get weak. Typically will weaken on you. And then you don't have any spring through here. The lats will get tight. They'll go to the health club, and they'll be doing pull-downs in the health club, and the lats will get real tight, but they're sitting on their butt. When they sit on their butt, this is going to be weak, and this is going to be tight. You have to have this spring through here because it's got, in this state, it's contracting into concentric contraction and pulling this shoulder girdle back, and since it's crossing over, this is right rotation of the thorax and left rotation of the pelvis. So you got the cross pattern gait going on here from behind, and at the same time, this is eccentrically contracting from the front. It has to give as the external obliques lines comes through the transabdominal fascia and into the adductor muscles, while internal obliques stabilize, and that has to work in conjunction. As this leg starts to come through, this becomes the concentric contracting muscles that start pulling this all the way through. And that's why Serge Grokowski is always saying, when you lose this right here, when you go run on the beach, and you're losing this ground reaction force into the ground, what happens? Your belly gets tight. The thing what's sore after you run on the beach when you haven't been on the beach in a while is your abdominal muscles hurt. And the reason they do is because this line right here is having to work hard. It's not used to working because we get weak abdominals, and this line gets weak. And so all of a sudden, with no ground reaction force, no help from the ground coming up, we've got to overwork this. So it's very interesting. Any kinks in here? You got a low back kink in here. You got a facet joint. You got a ligament damage. You got a hip capsule that's not right. You got a shoulder problem that's influencing latissimus here. You're going to have dysfunction. You may have inhibition. You may have muscle spasm, but it's going to take the nice torsional, the spring out of this thing, the strength in here that causes this to spring. So we've got to have that. And here's how I take a look at it in the sports applications in my book. Here's a golfer, a professional golfer we got in the studio, and it shows the stirrup spring system coming up through here as he's already going through on the follow-through. He's already made his swing. Well, why our golfers have low back pain is because they can't stop this swing. They can't stop this. If they swing, they go too far, they over-rotate because there's too much tension. Somebody's either overstretched them, they have hypermobility, or mainly they're just unstable in this back. They do not have good core support in the back, or there can be numerous other things. You got the posterior spring system coming through here. The lats can be too tight, and again, the glutes are going to be weak very commonly. And then you come through here, and maybe you've got an arch that's a problem and not letting you tighten the system through the arch here. And here is a very common problem on when he winds up to get ready to on the upswing. The line's coming all the way through his arm line, through the lats, and down through the contralateral glute max biceps femoris, and he's storing potential energy, getting ready to transfer his weight to his left foot and drive that ball through. This is elastic. This thing has to be taught. This line has to be taught. This is what separates the good golfers from the bad golfers, and the golfers that get injured from the golfers that do not get injured are the ones that have the nice coiled system, and then they just relax. Tiger Woods used to say that. I just relax. I tighten the system and then relax and let it go. And this is what the spine's supposed to be doing. This is neutral mechanics with the side bending up.
So Eric, how have you seen the field develop and change and grow over the years?
Well, when we started, everything was a muscle problem. When I got started out in massage college, everything was a muscle problem. Everybody that came in had a muscle problem, so that's what I focused on. Got to the Rolf Institute, and everything became a fascial problem. And saw Janet Travell in '89. Everything went back to muscle problems. And then when I fractured my neck and got interested in spinal biomechanics, everything became a joint problem. And you realize that things just keep changing. Now functional movement is very important, and it's always been important, and many of us have been using it for a long time as far as retraining exercises. But now with Gray Cook and Michael Boyles and Levinson and Professor McGill and a bunch of those people, we are really starting to understand how to integrate and actually test through the functional movement screen and other tests that are more sophisticated than the static anatomical landmark tests that we used to do. We're able to test where their weaknesses are and go directly to help strengthen those. So these are some functional movement things done by a couple of my teachers. This guy, Nick Kress here, he's just doing a little simple stretching exercise where he's rotating his torso to the left, whereas pelvis, allowing his pelvis to stay rotated. It's rotating left, rotating right, and this is rotating left, so he's got that counter rotation going on in there, strengthening that at the same time. And same way down here. And then as he lifts his hips up here, this is not a hamstring stretch. This is a stability stretch, and it's a core strengthening stretch, and it's also very good for the gluteals. And, of course, the foam rolling, we know all about foam rolling. This is using the TRX. Paul Kelly here is training Amanda here. This can be a stretching technique to stretch all this lateral stuff going on here, or it can be a strengthening for your leg abductors, whatever proves to be weak. You can do the Vladimir Yonda hip abduction test and see if TFL's substituting for the gluteus medius minimus, or if piriformis or something else is
Eric?
Yeah.
Eric, maybe you might say what the TRX is on the upper right, because I think most people don't know what a TRX is.
I don't even know what it stands for. Do you know?
Well, it was made by the military, Marines, for training out in the middle of nowhere. It's just a little tiny thing with really strong straps. Training, restraint, exercise, something like that. So that you could do it anywhere. All you need is a tree or a fence, and you can do a million exercises.
Exactly, exactly. And you know, the TheraBand makes a bunch of products now like this. They're starting to do some of this stuff where you can just hook them on your door and things. That's actually what I use. Some of their handles in my, I use do them with assisted squatting. I love squatting, and even with my knees, they've really helped me prolong my knees by doing squatting, but I use TheraBand as assistance. But yeah, that TRX, I didn't know that it was developed by the military, but I know it's a very, very wonderful and inexpensive and machine that a lot of personal trainers incorporate in their practice.
Yeah, it's great.
Yeah.
So, Eric, are there any aspects of what you teach that are kind of counterintuitive or surprising or challenging for students to learn?
Well, everything's kind of counterintuitive to me. I'm a little dyslexic, I think, but this was what fascinates me the most is Grochovetsky's spinal engine work. Judith Aston and many people for a long time have been talking about our systems are actually a spiraling system. The hips and the thorax have to kind of counter-rotate, as we talked about, and so there's a spiraling thing that must go on in the body. Of course, when we get to the neck, because of the facet joints, the plane of the facet joints, it kind of takes care of itself because it's not affected by this the rotation here in the thorax and lumbar spine. But this coupling has to be normal. And this is what Grochovetsky, this guy was a thalidomide baby, and he wanted to engage in these experiments with the Grochovetsky, and they hooked him up, wired him up with a lot of electroencephalographic equipment to try to find out how he had this cross-pattern gait without legs. And Grochovetsky was trying to prove to the community, but because up to that time everybody was skeptical about his gait model. They thought pedestrian model of gait, your hip flexors kick your leg forward and your hip extensors bring them back through. He said, no, that ain't happening. How are you going to have cross-pattern gait from that model? So he found a legless man that walks on his ischial tuberosities, his ischium, and found a pretty good cross-pattern gait here. And one of the things that drives this system, the thing that I talk about in my workshops, and to me the most important thing that we need to restore as manual therapists, whether you're doing in manual therapy or in functional movement therapy, one of the things that we have to focus on is restoring normal curve, as normal as possible curve, particularly to the lumbar spine. You cannot have cross-pattern gait with a spine like this. This is a chimpanzee spine, and a chimpanzee walks like my 14-month-old or 15-month-old granddaughter. They wobble from side to side, and why they wobble is because without lumbar curve, you do not have the ability to counter-rotate. If you have too much, it's going to be destructive to the disc, particularly L4, L5, possibly down to L5S1. But you have to maintain a nice, smooth lumbar curve so that you can get that cross-pattern gait. It's kind of a little bit complex in the spinal engine, explaining how it works, but it's fascinating, and it's something that this couple motion of the spine and the spiraling spring system that the body works with, if we don't understand that, then we can't understand tensegrity model, we can't understand what Tom Myers is talking about, and we definitely can't understand how to keep these discs from getting crammed, degenerating discs and ligamentous laxity that goes on in the spine. So this is the thing that most inspires me, and it's real easy as a manual therapist to restore this. It's a lot easier to take curve out of the spine than it is to put it back in, for me. Now with functional movement training, you can put the curve back in easier, but it's easier to take it out.
Great. So what advice would you give to a new teacher or a new therapist going out there?
Let's see, the passion. Get into it for the right reasons. I have people calling me and saying, I was going to this school here in this Votech school, and they wanted to know if I wanted to be a diesel mechanic, and I decided, hey, massage therapy might be better, and I just wondered if I could make more money being a massage therapist. I go, you need to be a diesel mechanic if you're asking that question. You need to get into it for the right reason. In the old days, we got into it because something happened to us. Somebody touched our bodies. It changed our lives, and we got into it because of that. If you get into it for the money and you say, I think I'm going to become a because I can make more money. That's the wrong reason. And yes, you might get it right. You might fall in love with it. It might be great. But the other thing is you got to keep educated. You got to keep learning. I love this quote. I put this in my first book. It was author unknown. Truly educated never graduate. And that's it. You're always got to keep learning, or else it's boring. I have one of the largest video collections in the world. I got into it back in 1982 and 83 when we were editing some of Ida Ross old tapes that Betamax tapes, and I happen to have some background in studio work from musicians field, so I got to go in and help edit those tapes, and I got hooked on learning from videos. So I have videos from all over the country, some of them in other languages, and every morning when I'm on my computer rolling machine, I got videos on. I've got your videos on. I've got on all your videos, and of course here's James Woslosky, a good friend of mine. I've got his starting back when he had the little red shirt on, those first very instructive videos that he doesn't like anymore, but I do. And of course Whitney, who was on last night with you, excellent educator, we all know that, and he's got a bunch of great videos. Tom Myers, and then I'm sorry I put this in. Well, I thought we were going to be doing this podcast ahead of time, so I jumped the gun on here. You guys taught February 11th, 8th to the 18th in Costa Rica. But, the stuff that you're doing, the podcast, the thing we're doing right now, people need to be tuning into this, and they are. People are listening to this. We're preaching to the choir, to the people who are already sitting here listening to this. But that's what keeps me going. That's what keeps me young in this business. Is even though I may not be out teaching 3-day workshops anymore, I've got my head in something that's going on. And Barb wants me to push that. Okay. So anyway, we're doing this thing right here at the American Massage Conference. This is the only thing I'm going to be teaching this year, probably. I know it's the only convention I'm going to be teaching, and I'm going to be teaching all day. April 20th, Woslosky and Benny Vaughn and Angie Patrick and a host of great presenters are going to be at this convention, April 20th, 21st, 22nd, in one of my favorite beach cities, San Diego, where I lived the last couple of years of my 17 years in California. And so you need to make it to this to this convention if you can, because it's really a convention for therapists. We've got chiropractors coming. They're going to be in the same workshops with massage therapists. It's going to be an integrated workshop convention, that something that I've been wanting to do for a long, long time, because I do get chiropractors and PTs and such in my workshops, so I'm glad to see them at conventions getting credit for it. So anyway, you can go on to this AmericanMassageConference.com and enroll in this one-day workshop, and be sure and check out some of Whitney and Woslosky's presentations too while you're there. So, yeah.
So I'd like to steal that
truly educated,
never graduated. I'd like to steal that. Is that okay?
Wonderful. Yeah, well, it's not mine, man. It's not mine. It was author unknown. To call it Ben Benjamin. Nah. Call it yours, yeah.
No,
I always do that. I steal from other people, Ben, but then when their teaching assistants are in my class, then I give them credit. But otherwise, I just say, I invented this technique, and they'll go, wait a minute, I learned that in Tom Myers' workshop. Oh, yeah, that was a Tom Myers technique. Never mind.
It's hard to, the kind of things kind of blurring these days. So many things are coming together. People are learning so many different techniques.
Yeah.
So, I know that you've written a great deal over the years, and do you have any advice to give to other people in the field, newer people in the field who are just coming up that might be interested in writing more in the field?
Well, I'm really a bad person to ask about writing. My wife has a master's degree in literature, and she's an incredible author, writer, and she's tried to teach me now. We've been married, been together since '84, and still haven't learned. This last book took me 3 years to write, and this one was about how long did this take, Barb? She's saying it took 2 years to do this. We got a new edition of this one out now. But this one I'm very proud of. We just released it a couple months ago. It's got contributing authors Judith Aston, Grokowetsky, Robert Irvin, D.O., Gil Headley, and Jerry Hesh does a wonderful chapter on sacral torsions. And Kai is a Rolfer and has some great research. Craig Liebenson, of course, does some functional movement stuff. And Till is offers some great stuff. Aaron Mattis, Tom, bunch of great authors in this, and so we spent a lot of time doing it. It's probably going to be the last thing that I ever do like this. Who knows? But the only thing I can say is get a good editor, get a good graphics person, get a good editor, and if you want to do it on your own, you better plan on having a lot of money, and if you're going to self-publish, have a lot of money and a lot of time to spend on it. But
a lot of time.
A lot of time, you know this. You've been through this many times. So, if you get an editor, Whitney Lowe and I were talking about that. I think his first book was self-published, and then I think the second time he went to a publisher. So there are good things and bad things about both, but it's sure a lot easier if you have a good publisher.
So let's go into some of the body issues now. So how do you understand and work with low back pain, chronic low back pain?
Chronic low back pain, which is what mostly I see in my practice. I don't really like to see acute low back pain, but I do take those people. They say, my husband's on the floor and he can't get up, It's like Pulp Fiction. I go, don't bring him here. But anyway, now I have them come in because I'm able to work with acute pain a little bit better. But anyway, we've always thought that chronic pain was a tightness. We got some muscle spasm there. We need to get in there and dig that muscle spasm out. Well, as you know, with all your ligament work with Dr. Cyriax, that ligaments, the muscles are basically just a whipping dogs. It's usually something else that's causing the spasm. It's something else that's causing the spasm. So do you want to get an elbow in there and dig that spasm out? That's the question. Because the low back, we realize now, it lacks stability. A lot of times our problem is actually coming from the hip capsule. We don't have enough range of motion in the hips, so we don't have enough range of motion in the thorax. And so it makes the low back have to work harder. And with all the cross-pattern gait and the counter-rotation that has to go through here, the torsional forces, it gets weak. And with a flexion-addicted society, when we got weak abdominals, weak gluteals, and tight hip flexors, it's going to put some patterns in here that are very hard to fix. I like to try to restore that, the sagittal plane stuff first, the Vladimir Yonda upper and lower cross syndrome patterns first for chronic low back pain. And you need to do all of I do still do the anatomical tests, as a way to gait analysis test, but this is one on Paul I'm doing. You can see he's got a little bit of trouble here in his spine right up in here, even though he's got great structure. He was a gymnast and has hurt it himself a couple of times, but right now I'm testing his ability of his lumbar spine to rotate. As he side bends to the left, I'm expecting to feel the transverse process of L4 here rotate back right against my palpating thumb. If it isn't, then I know we've got some sort of a joint dysfunction here that's either not opening here on the left or not closing on the right. So I make notes of that. I start checking his cross pattern thing. That's why I've got these marks drawn on him, seeing if the glutes are weak or seeing if the lats are too tight, checking these torsional patterns. Right here, I'm just trying to decompress. I put him in a flexed position on a bench. I bring him in here before I even ask him to undress. With their clothes on, I put a palm right here on the sacral base and bring them into forward bending and see if I can side bend them and rotate them and decompress L5 from the sacrum. That is the most operated disc in the body, followed by L4-5, and so you really want to get some decompression through here. So one of the best ways to start out is to see if you've got any joint play in there. Remember in 1955, Dr. Manel said there was supposed to be 1/8 inch of infall in every synovial joint. There's supposed to be 1/8 inch of involuntary motion that's not controlled by muscle action. So myoskeletal alignment is based on that. We try to get joint play in all of these joints, particularly glenohumeral, particularly hips, but in all the synovial joints too. So I got him in forward bending. I'm trying to decompress L5 off the sacrum, try to get 4 off 5, etc. And then in the ribs, you can spring the ribs into rotation, trying to see if there's joint play, see if the ribs are springing. And this is a thing that you're very interested in. What do the ligaments do how can they cause inhibition in some of these deep muscles like multifidus, or in this case joint dysfunction? This is taken from Professor McGill's research. He had an MRI, functional MRI going, and found that the guy was doing a squat and the joint subluxed, and immediately this multifidus started to become inhibited and weak. We always thought they went into spasm, and I still think for the most part they do spasm first, and then in time they become weak and inhibited. And of course these deep muscles, the multifidus rotatories, intertransversarii, are brother and sister with the erector muscles, iliocostalis and longissimus particularly. And so when you have dysfunction here, it's segmentally innervated, so it's going to cause those scoliotic patterns, facilitation or tightness in the rectors, which can cause scoliotic patterns and chronic back pain. You've got to mobilize them if it needs mobilization, and then you've got to give them home retraining exercises. If they're not going to be compliant with their home retraining exercises or strengthening exercises, then you've got to send them to make sure they go to personal training that knows how to test for functional movement. And every time they come in, make sure they're doing their bird dogs or their planks or their dying bug routines or any of the routines that you're giving them to try to create stability and core strength down here. Mm-hmm. Let me see what else I got here. Is there another one on here?
So what are you want me to go? You want to go and get you another question? Yeah. So what are some common postural faults and how would you approach them?
Yeah, this is that Vladimir Yonder thing. I skipped to that accidentally. This is a chart we have with a 12-pound head and in a fairly nice plane here. Pretty neutral, not too much weight going through it. But Kapanji and his physiology of joints and other researchers have found that for every 1 inch the head moves forward in the sagittal plane, you have to add 10 pounds to the weight of the head. So in this case, with the 2 inches head going 2 inches forward, that head now weighs 32 pounds. So the extensor muscles are having to hold this up against gravity, holding this head back against gravity. And then when it goes 3 pounds, and we see people going 3 inches forward, this is a little more than 3 inches, but we see this, and so that's 42 pounds. That's 42 pounds that these extensor muscles are having to hold back, and you get things like this Dowager's hump start to form. You get these internally rotated shoulders, tight pecs, weak lower shoulder stabilizers, this upper cross syndrome pattern, which is very common. So I like to start by correcting the simplest things I can see. I look for patterns. When people come in, I follow them down my long hallway into the therapy room, and I start watching them walk when they know I'm not watching them. I start watching them untie their shoes as they start to get undressed. I start wanting to watch what kind of movement patterns they do unconsciously. And so the first things I want to correct are that I look to say, prove to me that you do not have an upper cross or lower cross syndrome pattern. Prove to me that you do not have J. Gordon Zink common compensatory pattern. Prove to me that you are not right motor dominant with a right pronated foot, right anteriorly rotated ilium, left posteriorly rotated ilium, whatever. So I look for patterns, and I try to see if those patterns are there. If I'm not getting having any luck with neck pain, I do a couple of simple evaluations. This is the Brugger test. I have Luke standing here, and I'm palpating the suboccipital muscles. I find something that's tight in the suboccipital, one little suboccipital muscle that's tight. I hold on to that, and then I have him sit down. If it gets better when he's seated, then I know the problem isn't in the neck. I know it's coming from the lower quadrant. He has an unlevel sacral base. He's got foot pronation. He's got something that's causing the problem to have to compensate up in the cervical spine, particularly at the OA or AA joints. And so I use that, and I also use this Vladimir Yonder neck flexion test. Just say, pick your head up off the table. When they pick their head up off the table, if the firing order is correct, longest capitis fires first, longest coli should fire next to cock the chin down, and then sternomastoid can fire to pull the head up. But if it's not, in Luke's case here, he goes toward the ceiling in the first 1 or 2 inches, then I know sternocleidomastoid is overpowering the deep neck flexors, the longest capitis coli. I've got to create tone in that, plus giving him home retraining exercise, strengthen that firing order pattern, make sure the anterior scalenes are working properly and they're not overpowering the longest capitis coli. So those are some simple tests that I use to evaluate for neck pain.
How would you handle a knee injury? Well, but where would you approach that?
Well, I'm always changing my mind on knees, and knees are very complicated actually, because it's usually not a knee problem. I have a new chapter in my new book. I have a chapter on this called "Weaken the Knees." We see a lot of stuff that we really can't help too much. This is articular cartilage degradation, I've got this problem with the posterior cruciate ligament back here. This is the anterior ACL problems. We can help people get become stable through here. But basically, a lot of the problems that we see with knee problems, such as IT band friction syndrome, which is kind of in doubt now whether that actually exists, whether it's actually gliding back and forth, that IT band is gliding back and forth on the across the lateral epicondyle. I personally don't believe that's what's happening. I believe that we are having that the IT band is not really the problem, that a lot of the problems coming from the synovial lining of the joint, and that comes from research studies done by several researchers starting back in 2007. And so an inflamed synovial lining, in other words, it can get caught in the joint capsule and get pinched and start to become inflamed and put pressure in here, and you can get pain under the patella. You can get all this lateral knee pain, and it can refer back and forth and create a lot of problems. And you end up getting this stuff done, arthroscopic surgery, where they go in and try to repair some of that the damage that has been done. And sometimes it's effective in cleaning this out. Sometimes it's effective in cleaning the meniscus out, particularly very good at repairing menisci, and the ligamentous structures. But really, the knee is a slave to the hips and ankles functionally. In other words, the knees, if you have imbalance, if you have restrictions in a hip capsule, and the hip isn't moving in the proper manner, you have weak hip abductors, abductors, or you have foot pronation, you have weakness in your arches, it's always going to affect the knee. This is a common problem that we see, and that is an externally rotated femur, and then an internally rotated tibia and pronated foot. So in other words, when the person heel strikes this flat foot, it gets stuck in internal rotation. And then if you have, like this knee right here, look at this knee. It's coming up. You got the pronated foot on this side. You got hyperpronation of both feet. But look how it comes up through here. This one comes up, and because this hip is more in external rotation, you can see that's more external, this is more internally rotated. So these are typical knock knees, and this is not going to have as much knee dysfunction on this side, because this is a bad torsional twist that develops here, because you've got this one kind of externally rotating, so it's grinding on the articular cartilage here, and this is where that lateral part of the knee can get, the synovial lining can get caught in there. So you want to try to get rid of that. There are several ways you can do it. First of all, you need to do some knee strengthening techniques. Here's Paul doing some things that can help strengthen weak knees. And if you can't squat, you can do these sort of things. Can help also lengthen, the hip flexors. If you've got a tight rectus femoris and iliopsoas, rectus femoris may be causing some patella problems. We used to call it chondromalacia, but patellofemoral pain is a proper word for that. And this is another common problem I see at the knee right here, is somebody comes in with a biceps femoris tear. Runners, a lot of runners get hamstring tears. And biceps femoris is the most commonly torn one, possibly because of its dual innervation. And it'll get short. If it's a pretty bad tear, it can get short. That muscle can tighten down. And, of course, its distal attachment is on the proximal fibular head. So it has a firm attachment on this fibula that's running up through here. Well, what it does is it pulls that thing posteriorly, and then that fibula gets stuck posteriorly. So you got to make sure that thing is back. You got to push it back, or it's going to imitate all this lateral knee pain stuff. And I've had several cases of people who've had surgery to go in for a lateral release, where they go in and release the lateral retinaculum with all that stuff is attaching, because that's really the key, is the lateral retinaculum. So many things attached there that it will pull the knee over to that side. I'm going to look at this again here. We always have talked about vastus lateralis. overpowering vastus medialis, but it's much more complex than that. It's not a simple matter of muscle imbalance between lateralis and medialis. You got to take the IT band and the tensor fasciae lata into account, because it also, before it comes down and attaches to Gerdy's tubercle, it has a firm attachments here to this lateral retinaculum, and so do a lot of other structures. And and they start to pull this thing laterally, and that's where we see these squinting patellas. The patella it no longer has good tracking, and so it starts to wear on the underneath side of the articular cartilage of the kneecap, and so people get they start getting runner's knee and conditions like that. All of these structures have to be corrected through retraining exercises. This is a great one right here, for instance. This is an Eiderolf. Tom Meyer says Eiderolf didn't teach this, but I swear she did. But he says that it's an Eric Dalton technique. I call it the log roll. And what I'm trying to do here is, in that pattern that we just saw with this externally rotated, we got an externally rotated femur here. I'm trying to internally rotate this femur. And so I'm pulling this thing into internal rotation, pulling the whole leg in internal rotation, keeping the knee straight. It has to be straight here. And then I ask her to visualize that big femur bone moving within the fascial compartment as she externally rotates this entire leg. I hold this tissue and don't let it move. When she relaxes, takes a deep breath. When she relaxes, I pull it into more internal rotation. What that does is I'm holding the whole fascial bag, this whole envelope. I'm holding everything, and it turns the femur into external rotation. And when I let go, it pulls it all back into internal rotation, helps take that torsion out of this femur. Very quick, one of the most powerful techniques that you can use, because you're getting the hamstrings from behind, you're getting all the quadriceps stuff, you're getting, of course, all the fascia, adductor fascia, and all that stuff. And then you kind of got to come in and do some of the tibia work, which we can look at in a little while. Plus your retraining, your ball retraining. Here's Paul retraining Amanda with squats and bringing some core stability while they're doing some good knee work, some simple stretching here by Nick. And also what Whitney Lowe is saying, listen, when you got knee problems, one of the best tools you've got is palpation. Use your fingers, use your thumbs, come in here and palpate for the painful area. Sometimes the pain is directly where it says it is. Very commonly you'll see pain on this medial side under the kneecap. That's very typically a medial meniscus problem. But it can be other things, but that is a very, very common finding. Notice how I'm sitting on this PT's foot here, and I'm also going to give him a shelf test. I'm going to pull this out to see if I have any slop. If there's any slop in here, I know that he's got an ACL problem. As I push forward to test the posterior cruciate ligament, I push all this forward, and if there's slop going that way, you've got a posterior cruciate problem. So you can just do a bunch of good tests by just getting the knee inflection and going through some of these things.
And you got to tell your client that you're going to sit on their foot, or else they think you're a little weird, right?
That's right. Yeah, sometimes I forget to do that. And that's, of course, all my clients are friends. They come off and on to me for years and years. But yeah.
So let's move from the knee. Let's move up to the head. How do you understand and approach tension headaches?
Gosh, there's so much to headaches like low back pain, isn't it? Just so much to understand.
Just give them a little bit, though.
Yeah, okay. Well, how much time do we have here? How are we doing on time?
We're coming down to the end, but it'd be nice to finish everything. But all right, maybe take another 5 or 10.
Okay, we're cool. Well, most people focus on the suboccipital muscles, and of course they are pain generators, but not in and of themselves. There are other things that can cause pain. One of the things I see is these postural patterns where you get jaw retrusion. In other words, the cranium is not formed out of the same myotome as the jaw and the zygomatic arch. They're formed from different myotomes. This all belongs to the gut. This is the belongs to the stomach and everything. This belongs to the cranium. So anyway, when the head starts to go forward, the jaw may not. If the hyoids are tight, it's going to pull this thing, the jaw, into retrusion. A retruded and overclosed jaw is a very common initiator of vascular type headaches. And one of the other things that I see is the jugular vein has to come down through here. We've got the carotid arteries and vertebral arteries pumping blood up to the front and back parts of the brain, but the main release of blood out of the cranium is through the jugular vein. And if there's any OA, AA, jaw retrusion problems up here, particularly OA problems, occipital anal problems, then you can get constriction of blood out of the brain, and that's when they got those pumping vascular headaches. And so that's, in my opinion, and this hasn't been proven, a lot of it comes from right here. This is a very, very critical thing, and understanding this concave convex theory of the OA joint. You've got a convex surface on the condyle here, and a concave surface that sits in a cup here on the on atlas, and so it has a rotation and side bending occur to opposite sides. You've got to understand this mechanics. It's very simple. Atlas axis mechanics are simple. This is simple, but if you don't understand it, you're going to miss a lot of headaches. You're going to miss a lot of upper cervical problems and a lot of upper neck problems. So here's some techniques for it. This is one where I'm coming in and working anterior scalenes, very simple technique for anterior scalenes. Here I'm mobilizing the facet joints with my thumb in the lamina groove, pushing on the bodies of the spinous processes as I side bend Luke to the right. I anchor at wherever I am, in this case C4-5, and try to see if C4 is moving on C5, etc. You can take the head into flexion and extension to test for whether the joint's opening on one side or not, closing on the opposite side. The atlas axis technique, all you do is bring them up into full flexion until you ligaminously lock all the typical cervical vertebra, and then you turn the head. It's supposed to have 45 degrees of rotation in each direction through the atlas axis joint. As long as you've got them ligaminously locked through here, you're only testing rotation of atlas on axis. A very, very simple technique. If they're hypermobile, this technique doesn't work. You have to do a little more complex analysis. This is putting cervical curve back into the neck. I've got nice body posture here coming down through here, and I'm asking Luke to turn his head while I brace here, and as he relaxes, I start to strip up, trying to pull cervical curve. That's one of the things that we lose. Your chiropractor will say you have a straight neck. He doesn't really mean you have a straight neck. He means you have loss of cervical curve. Excuse me. So that's what I'm trying to do there, is restore cervical curve. So there are dozens of different kinds of techniques that we use for tension headaches, neck techniques, and everything. That's just a couple of them.
So how did you work with a side-shifted rib cage?
Yeah, a while ago when I was working on Paul there, that's a typical pattern that you see, those rib mobilization things I was doing earlier. Here's a more dramatic case where you have a true structural scoliosis. This gal, these pictures weren't taken by me. I don't take pictures with people in the nude. But we used to take roughing before picture sessions 1. I sent this over to an old chiropractic friend of mine. You can tell it's in black and white. We did this in the 80s. Amy came to me. She didn't want to come. Her mother forced her to come. She had a big sweatshirt on, wouldn't look me in the eye, and this is what she looked like when she came in. And as soon as she allowed me to palpate her through the sweatshirt, and I was actually surprised that when I put my palm here on her spine here, where her spine is actually side bending to the left and rotating to the right. So this is a big curve going on here. She got a lot of problems at the thoracolumbar junction here, and so she actually had spring in the rib cage. She was 12 when she first came to me. 12 or 13 when she first came. This is 2.5 years later after therapy, and she got a lot better. She still got a lot of problems, but she looks a lot better. And she moved out of the state, but I see her every few years, and her structural scoliosis is good. But for this side-shifted rib cage, which is an actual a deformity, really, this is not. This was something that happened to her, and we don't know why it happens, hormonal or whatever that happens to young girls particularly. This is usually called a fixed scoliosis. Well, don't ever give up on these fixed scoliosis, because with every structural or fixed scoliosis, you have a functional component that is also that can be fixed, and every single one of them can be fixed. Notice how her head is side shifted. It's better here. It's still not good, but we fixed her from above a little bit. We got her a little bit better from above, and notice the feet, how she was weight bearing. One of the first things I tried to do is right here. She was weight bearing so much on this hip, it was causing her to hyperextend this knee. I took that hyperextension out of this knee, got her so that her pelvis was more level. Once we started leveling that sacral base, everything started getting better. I had the chiropractor do some adjustments through here. But on a side-shifted rib cage, you have to work on this thing. Then you also have to do some other things. You have to open up the short side. So I come in and do techniques like this that open up that short side. I come in on the and stretch the side that's got the hump. I'm going to want to stretch that side and try to bring it back around. But mainly one of the things that people don't do is they don't open up the front part of the body. They'll work on the back side of the body, but they don't come up here on what we call a transabdominal column. So they've got a problem straight through here. If they've got a right thoracic scoliosis here, you've got to come in and get this line going across here. The short line is going to be here. This shoulder is going to be coming forward toward this hip. And so you've got to take that out of there. And so that's one of the things that you have to open up, is that diagonal line across the short side of the body. So if they have a right structural scoliosis, which is what she has here, where the vertebrae are side bending left and rotating right, this is the short side on her, and this is the side which is her left hip. And so it's the left side that you're going to want to open up, to get this side all opened up. Plus that, you've got to open up the front, all the front line, and particularly the pecs, all the way down the arm line. Got to come all the way down through here, open up the front line, and use some of these techniques.